Hi guys, this is gonna be a overview of anesthesia as such and what we anesthesiologists do in the OR. Okay, so broadly anesthesia as such is divided into two, like the general anesthesia and the local anesthesia or the regional type, where you can block separate areas according to the area of surgery which you decide to do. Well, now going into general anesthesia, like you would have heard that or read about it, like general anesthesia. So what do we do in general anesthesia? There are three important aspects. Like, we'll have to induce the patient, then give him some pain relief. Okay, so pain relief, and the third one being relaxation for the surgeon to operate on it. So these three aspects have to be covered. Let's start with induction has two varieties or different types which can be done. One is being the inhalation induction, and the other one IV induction or the intravenous induction. So inhalation induction is by giving gases or vapor form of inhalation anesthetics like isoflurane, sevoflurane or desflurane, which is the latest one. And previously we used to give ether or halothane. These were pioneers in inhalation anesthetics. Secondly, so basically inhalation anesthetics are used in pediatric age group where the patient or the baby cannot be an IV access cannot be started prior to surgery. So inhalation anesthetics can be used in those cases. When there is an IV access already in place, the IV induction is always preferred. In IV induction, we have different types of drugs which can be used, like benzodiazepines, the thiopentones, and high dose opioids can also be used, like in case of cardiac cases where high dose opioids are preferred. This is for the hemodynamic stability which can be maintained using high dose opioids. So induction with thiopentone or benzodiazepines, which are usually thiopentone sodium. Okay, and then benzodiazepines we have midazolam, which is the most commonly used in cardiac cases, which has better cardiac stability than the thiopentone, which causes more of a hypotension. Thiopentone or the benzodiazepines. Next, we go on to the pain relief or the analgesics. So, for any surgery, you will need proper adequate pain relief or analgesic, which can be an opioid, preferably a fentanyl, which is a faster acting opioid and more potent one, which is usually given at induction. So we start off with fentanyl up to 2 mics per kg body weight, and then we go ahead with induction with benzodiazepines or propofol, which is being the latest one, and also more preferably we've got etomidate coming into the market. So after induction, before induction with any of these, fentanyl is preferably given. So once the opioids like fentanyl and morphine is also being used in some centers, once we have given the induction agent and the patient is put to sleep, then we move on to give the muscle relaxant. So muscle relaxants, you would have known about, you would have heard like two of them. Coming to the relaxants, you would have heard about the depolarizers and the non-depolarizers. So depolarizing muscle relaxants is the one and only one which we use more commonly is the succinylcholine or the scoline, what is usually called as. It's a very ultra short acting muscle relaxant, and it's a depolarizing muscle relaxant. So these are usually used in rapid sequence intubations requiring very immediate intubation in patients who might have a full stomach, considered full stomach, or in cesarean sections where the patient is considered a full stomach. So to prevent any kind of aspiration, to go ahead with intubation, we just give succinylcholine, wait for 40 seconds, and then go ahead with intubation. Along with the Selix maneuver, where the cricoid is pressed over the esophagus to obstruct any kind of regurgitant. Nextly, we go on to non-depolarizers. Non-depolarizers, there are three different types which can be used. One being the short-acting, the moderate-acting, and the long-acting. So short-acting, consider like atracurium and cis-atracurium, and medium-acting will be the vecuronium, the long-acting being pancuronium. So any one of these can be used after scoline has been used for induction, and once the tube is in situ, one of these non-depolarizers can be used to maintain a proper relaxation during the course of surgery, and can be repeated intermittently depending on the duration of action. So once the surgery is over and the surgeon is done with his job, we'll have to reverse the patient. So intraoperatively, you would have used some inhalation agent along with O2 and air or nitrous oxide plus inhalation agent of your choice, which is available, so being sevoflurane. And along with this, the non-depolarizer shall be given intermittently every 30 minutes to 40 minutes, being repeated the doses. And once the surgery is done, we cut off the nitrous and the sevoflurane and give him 100% oxygen and reverse the patient from the muscle relaxant using neostigmine and glycopyrrolate, or you can use myopyrrolate, which is a combination of both these drugs for your muscle relaxation to be reversed. And once the patient is breathing spontaneously with adequate tidal volumes and adequate respiratory rate, and you're happy with that, you go ahead with extubation. So that will be the a gross idea of general anesthesia being administered in the OR. So thank you guys.